The final presentation of this afternoon is going to be by Searle. Helen is a nurse in Halifax and is actually Danny's, I shouldn't say Danny's nurse, Danny is Helen's medical oncologist. And she's an outstanding person. She actually wrote the number of years she has of clinical experience, which I cannot believe just looking at her. But she's going to provide, I think, something to end the day very well on in terms of the perspective from the clinic.
Thank you. It's been a great day, and it's good for me to see so many familiar faces here, so it's great. As Jeff said, I have been around for a while. I have been nursing for approximately 31 years. My career has spanned from maternity to geriatrics, but 20 years has been related to oncology nursing, both on surgery and in clinic areas. I've been working with Dr. Racing for a little over 3 years, and our neuroendocrine practice at the QE2 has grown over the last 3 years, and we care for approximately 80 patients from 3 provinces now. So it's very exciting. Neuroendocrine tumors can be difficult to diagnose, as we've heard throughout the day. And you may have had several visits to your GP over several months or years with symptoms that just couldn't quite be diagnosed. They were vague, they'd occur, then settle down. And usually, the diagnosis is usually made if you end up in the hospital, require some surgery, end up with a bowel obstruction or obstructive jaundice that you end up requiring surgery or a stent, or you end up having a CT or something that ends up determining your diagnosis. And the only way to really confirm the diagnosis is with a biopsy tissue sampling, which can show us your diagnosis of the neuroendocrine tumor. The only way you may have your diagnosis initially discussed with you by a surgeon, family doctor, gastroenterologist, endocrinologist, and then they send a referral to us, and you meet me first. I don't know if that's good or bad. We understand that you and your family are feeling very anxious and fearful because you have heard the word tumor or cancer. But the goal of our meeting is to explain to you the differences between these kinds of tumors and other kinds of cancers. I explained to you that these tumors are very treatable and that our patients maintain a good quality of life, and usually for a long time. Rarely do they require chemotherapy because these cancers are very different from the others, such as colon or breast cancers. And we try to encourage you to separate what you've heard about a lot of other cancers and put that to rest, because these are somewhat different. I'll ask you about the symptoms that you've had and how long you have had these symptoms. I'll ask you if you've already had surgery and if your symptoms have improved. I'll also ask you about your overall general health, what medications you've been taking. Do you know why you're taking these medications? Because sometimes people aren't quite sure. And then I'll explain to you the tests that may be done for us to see what treatments are best for you for the kind of neuroendocrine tumor that you have. And as you've heard throughout the day several times, a lot of these tests may include CT, MRI, PET, blood test, urine test for 24-hour urine for the 5-HI-AA, and a triatide scan or an MIBG scan. And these both have to be done at our facility at the VG. Or you may not require any of the tests above, because if your disease is stable and it's been determined that it was pretty well removed out of surgery, then we just monitor you. We need to determine if your tumor is functional, hormone-producing, or non-functional, non-hormone producing. And we also need to determine whether or not you have carcinoid syndrome. So flushing of the face or upper body, watery diarrhea, abdominal cramps, heart palpitations, or shortness of breath. In general, carcinoid syndrome can develop when tumor cells spread to the liver. Lung carcinoids can also cause syndrome even if there is no spread to the liver. And also remember, if you have carcinoid syndrome, you may have only one symptom. Some of these symptoms can be triggered by certain foods, alcohol, stress, exercise, or surgery, and it can happen for no reason. Carcinoid syndrome can also cause valve damage to the heart. And as we heard earlier today, it doesn't happen often, but we have 7 patients with successful valve replacements. One of those patients who's a postal carrier and back doing his route full time. So we do have some very good success. The treatments for carcinoid syndrome and non-functioning neuroendocrine tumors. Other therapies and treatments available to treat the neuroendocrine tumors are surgery to remove primary tumors, which we've heard a lot about today, reducing the tumor size, called debulking, to help reduce the symptoms, and the MIBG therapy, which is only done at the BG here for us through the Atlantic provinces. And we work very closely with our colleagues in nuclear med to get this organized. And we are doing more and more of these as time goes on. Hepatic artery chemoembolization done by interventional radiology. We have done a few of those as well. And the targeted medical treatments involving pills such as everolimus and sunitinib. So some of the other treatments for the carcinoid syndrome may include the following, depending on symptoms. The sandostatin injections, which include a monthly injection of the drug sandostatin, and the amount is based on the severity of the symptoms. And as earlier was stated, there are also daily injections that can be given to help symptoms if it's difficult to control with only monthly injections. So when you come in for your appointments, we always talk about your symptoms, how things have been going, or if I get phone calls that things are getting worse, then we try to make changes to the treatment. If it's determined that you need the injections, I arrange for this to be done. First needle is usually given by your family physician, and then a registered nurse is arranged through the Access Sandostatin LAR program. And I have to say they have been absolutely fantastic. I never have any difficulties with them when I'm arranging to get this done. Some drug plans cover this drug, but if not, it would be done through Access Sandostatin. And all patients have access regardless of financial status. And this is one area that we're extremely lucky. And I register all the patients with the Access Sandostatin LAR program regardless of their drug coverage, because if anything did change, then they're registered. Once we determine where you are with your neuroendocrine disease, we then determine what follow-up will be needed. Some patients will require more frequent follow-up with CT scans or other diagnostic testing. Some patients will only require annual CT scans because they've got disease stability. Some patients will require more frequent 24-hour urine collections for the 5-HIAA. And this is all determined on the individual and your current symptoms. And all of my patients know how to get in touch with me, and if things change before their next appointment, then we bring them in. But mostly I want to say I thank my patients, your families, for the privilege of being involved in your care, and our goal is to provide you with the most updated and expert care you deserve. Thanks.